Get ready to take a flamethrower to the official narrative and learn what the elites don't want you to know. You're listening to The Tom Woods Show.
Hi, everybody. Tom Woods here. It's episode 2551 of The Tom Woods Show, and we are joined once again by Dr. Jonathan Engler, who has a background in medicine, in law, and business. He is on the executive committee of PANDA, Pandemic Data and Analytics. You know our good friend Nick Hudson is associated with that. That's his organization. And also the UK-based Heart Group. And he has a Substack appropriately entitled Sanity Unleashed. And we're going to dig a little bit beneath the surface today regarding what really happened in 2020, and particularly in a couple of especially outstanding cases. So, Jonathan, welcome back.
Hi, thanks for having me on.
I'll tell you, the reason that I thought to bring you back was I saw the piece you wrote that I think indeed you released on your Substack, explaining why you asked to have your name removed from the Great Barrington Declaration. So let me just remind people, I'm sure most people remember, but early on in this whole COVID fiasco, several professors, Bhattacharya, Martin Kulldorff, and Sunitra Gupta, drafted something called the Great Barrington Declaration, in which they decried the lockdown policy and said that we would be much better served by implementing a policy of so-called focused protection, of making sure that people who were most vulnerable to this illness were given special consideration so that the rest of society could function. And a lot of people who were horrified by the various interventions up to that point very eagerly signed on to that, yourself included. But then something happened as time went on, and you looked more closely at what you believe really went on during those critical early months, that now you actually think that whatever its good intentions, the Great Barrington Declaration may in fact have been counterproductive. And I'd like to dig into that because that interests me. So explain the evolution of your thought here, that you would go from being, I assume, an enthusiastic signatory to now somebody writing a letter like that.
Yeah, I mean, the first point to make is that it didn't just happen overnight, that I woke up 2 days ago, whenever it was, I wrote that piece and decided, I need to get my name withdrawn from this document. It's been something that I've been thinking about for a long time. And in the end, I was looking for a framing device to explain my position as to why I disagreed profoundly with what that declaration said. And so I decided to write an email and ask for my name to be withdrawn, and write an email that could be published publicly that explained what I was doing. I think that to explain more about the evolution, obviously, when I first signed the Great Barrington Declaration, my main concern was, these lockdowns are going to cause havoc with society, havoc with elderly and vulnerable people, and it seems a very sensible position to take, that let society carry on, the people who are at apparently low risk of something, let society carry on as normal, keep society open, but give some sort of protection to the most vulnerable parts of members of society. And that seemed to be basically just common sense at the time. But as time went on and we started to delve into the data around 2020, I started to become slightly cynical about the whole concept of whether or not there was a pandemic at all, and whether, in fact, had we done nothing, we would have noticed anything out of the unusual happen. So, to take as an example of what they call sort of focused protection, if you look at Sweden and Germany as examples of what went on in 2020, people say, Sweden had a high death rate because it had no lockdowns. But actually, if you delve into the data in detail, you'll see that the reason that Sweden apparently performed well, as they say, is in fact because, to go back, go back. The reason why, I'm sorry, I'm getting mixed up with Germany. The reason why Sweden performed badly, and therefore it was in the early days of the pandemic was open to criticism, was simply because it carried out the same care home policies as were carried out in many other countries, such as, for example, the UK and the USA. And so there was a high death rate of vulnerable people in Sweden in 2020. And the reason why Germany was said to have performed well, they said that it had stringent lockdowns and that's why it did well in 2020, was simply because they didn't have these dystopian care home policies in 2020. So that got me thinking as to say, well, actually, was it something to do with what was done to elderly and vulnerable people in 2020 that caused the reported death rates? And was it something very specifically done to vulnerable people? And as a result of that, within Panda, we started to delve into the data, particularly in Italy, which of course was, taken as the sort of opening salvo, really, in the global spread. There was a story about the workers, Chinese workers, coming to Lombardy and causing the outbreak there, and started to look into Italy. And actually, with a colleague in Panda, who is an evolutionary biologist and very competent statistician as well, we started to look at the notion of spread, whether there was something actually spreading in Italy. And you can do this by, if you can get fine-grained enough data, you can look at the excess deaths in villages or towns and see if there's any notion of spread. And you can actually analyze that statistically to see whether there was something potentially spreading. And what you see when you analyze the data in Italy in fine-grained terms is that actually it looks like there was basically a cataclysm hit a certain area all at once with no notion of spread. And in the article that I wrote 2 years ago, I actually likened this to the analysis of a forest fire. So if you come across a burnt-out forest fire after the event, if you asked somebody, well, was that caused by, let's say, an explosion in the sky, which sort of incinerated everything simultaneously, or was it caused by something spreading from a point source? You wouldn't actually know after the event. You could only find out the answer to that question by looking at the fine-grained data in a time series to see if there was actually something spreading. Because if there's something spreading from a point source, you would expect, wouldn't you, to see one area would alight and then maybe branches would light off and fall off and sparks would fly and another area would light up and then another area would light up. And over a period of weeks, the whole forest would become ablaze and then it would all go out over a period of days or weeks. It would all sort of smolder out and you'd be left with smoldering there and a bit of a fire there and a bit of smoldering there. But if you look at what actually happened in northern Italy, the whole thing lit up at once and then went out all at once. And that's not really what you would expect to see from a virus spreading from a point source. So that got me thinking about whether or not there was actually something to do with the administrative process or the things that were done to people in response to the perception that there was a novel virus spreading in the area. And of course, around that time also, I was contacted by Jessica Hockett. I don't know if you've had Jessica on or not, but do you know Jessica?
I follow her on Twitter.
Follow her on Twitter. So she basically has repeated, using from a different angle, she has repeated the same exercise with New York City data. And in fact, we've done a number of podcasts together. We've written a number of articles together. And basically, in New York City, again, there is absolutely nothing cooking until the authorities say, 2 weeks to stop the spread or whatever the phrase they use is. And then there is this reported vertical takeoff in the number of deaths for a relatively short period of time within New York, 27,000 extra deaths over a period of just 7 or 8 weeks. And then again, a complete collapse in the number of deaths down to zero after a certain time point. And these are incredibly unnatural events. And that's what really got me looking into the question of whether or not we actually had an event which was caused by a spreading pathogen, i.e. a biological event, or whether in fact what we had seen was what you might term as a socio-political event caused by policy or the response to the perception of there being something present. Does that kind of explain to you how I got there?
Yes, it does. Yeah. So now we can get into a little bit more detail. Now, I'll tell you something. Every bone in my body wants to adopt your position on this. Okay, every bone in my body, after everything I've read and seen, wants to say everything we think we know about this is completely upside down. One thing that's holding me back is you may have seen articles arguing that Sweden did the best of the European countries in terms of excess deaths, and yet they had probably the most laissez-faire government policy toward all this. And so I've seen charts where they show in numerical terms, they rank the various European countries in terms of which had the fewest excess deaths. But the point is, these charts, now I admit, off the top of my head, I don't remember the source of the numbers. I don't know what the method that they used was. I grant you that. But these charts all show they do show that some event occurred. So this is the reason that when people say, "Oh, there was no pandemic and we wouldn't even have noticed," I say, yeah. but yet I have this chart that shows that apparently there was some kind of event in a bunch of countries. Or why do the numbers show at a statistically significant number of excess deaths? What am I misunderstanding here?
Well, what you're misunderstanding there is that the way we deliver health and social care is a complex, evolved system. And if you disrupt it, you are almost certainly going to have unexpected second or third order effects, which will be harmful. So I would say that if you were to just sit down one day and say, I go through this in one of the articles on Northern Italy, and say that if the government decided one day it was going to, there was actually no pathogen, but they just decided one day they were going to make people think there was a pathogen by identifying some test that was not accurate, but identified there was a pathogen, even though there wasn't. And you said the response to that would be that those people had to be isolated. Those people, the carers for those people would become terrified of people they were caring for. No relatives would be allowed to visit. People would be denied normal hydration and normal food and sometimes abandoned. And if people tested, if medical staff tested positive for this test, they would have to stay at home. Even if one of their children or one of their relatives tested positive, they wouldn't be able to turn up at work. And you put this huge spanner in the works in terms of the way healthcare and social care is delivered. That is inevitably going to result in deaths. Absolutely, completely inevitably going to result in deaths. So the very fact that there are some excess deaths resulting from the perceived response to there being a novel virus doesn't mean that there necessarily was a novel virus circulating.
All right, folks, let's you and I talk. We both know there is no chance of getting the truth about what's going on in the world by watching CNN or any mainstream outlet. We know that. We know that even the headlines in the news are propaganda, even the headlines. But those headlines become tomorrow's history. So what is the chance that you're going to get a reliable overview of American history through a mainstream source? About as much chance as you have getting the news from CNN. So that's why old Woods here is giving you 2 free big courses in U.S. history. Absolutely free. Don't cost you nothing. And we're going through the colonial period all the way up through the end of the 20th century. And it's revisionist in the best sense, that it takes the standard narrative and it smashes it into pieces. We open up your head. We dig out anything that was put there by people who hate you. We replace it with the truth. Then we close your head back up. That's what happens with my U.S. history courses, and you get them for free. Doesn't cost you a cent. So, for yourself, for younger people in your family, to take a long drive and make it worthwhile intellectually, you can listen to them anytime, anywhere. Head over to woodshistory.com and get them. woodshistory.com. I see. So in other words, those numbers are consistent with the story you're telling, because it could very well be that the various factors, and maybe we'll talk about them, at work in the healthcare system itself and in the social response were such as to be very likely to lead to some extra number of deaths.
To develop that line of questioning a little bit further, if you think that there's, I've already described that the way the health and social care is delivered is complex. So, and certain places have immense overcapacity. So, for example, Germany has immense overcapacity in its delivery of healthcare. It's very well funded. It's actually very decentralized in Germany, and it's well organized and well funded with lots of capacity. The UK, for example, is a highly centralized system with very bureaucratic and always generally operating at very, very high capacity. So it's very vulnerable to any disruption in the complex system that is UK healthcare. And in fact, all countries have developed over decades, developed ways of delivering health and social care, particularly to elderly and vulnerable people, that are slightly different. But they all have one thing in common, which is that they're all complex. They're all amenable to potential disruption. And what amazes me is that you've got in the notion of the COVID-19 pandemic, you've got one thing that is constant, which is said to be a novel virus. And you've got all these things that are incredibly different between different places. And yet, when people discuss who had a good pandemic or who had a bad pandemic, who had good outcomes and who had bad outcomes, they never want to look at the thing that is different between all these places, i.e. the healthcare system delivery, political responses, social situation of the vulnerable people, the legal framework, etc. They never want to look at that. They only ever want to think about the virus. And of course, this virus, which, as you know, I don't believe there was a novel circulating pathogen, but the story that they're putting forward is that there was one constant, the same virus spreading across the world, causing this pandemic. So why do they not want to think about the things that are known to be very different and variable between places as explanations for different outcomes, instead of which focusing on the thing that they are claiming is actually identical? So to take for an example, there's the border cities between the USA and Canada. I mean, USA cities near to the Canadian border experienced very high levels of levels of excess deaths during what they call the first wave of the pandemic. Yet the Canadian cities, a short distance across the border, in 2020, basically had nothing. The same in Germany. So Germany, you've got this northern Italy, where there's this cataclysm. In Germany, there's 2020. There's basically nothing happening. Certainly until that winter, there was absolutely nothing happening. How can that be? I mean, looking at Italy further, northern Italy against southern Italy. Southern Italy basically didn't have a pandemic, really, or certainly in 2020. I mean, I would claim northern Italy didn't have a pandemic as explained, but the point is that northern Italy and southern Italy had completely different outcomes from what went on. These differences in what happened. We don't need to look towards. We shouldn't be looking towards the complex unknowns about virus spread and humidity, etc., etc. We should be looking at administration, health system, social care, and policy and politics.
Is it your opinion that a good portion of the explanation for the deaths that did occur has to do with the, especially the beginning, the various hospital policies that were adopted, supposedly to fight against this pathogen? Is that part of the answer?
Well, so the first point to make in answer to that question is that I don't necessarily trust the excess death data as reported.
Okay.
So we're talking about it. We'll be talking about an assumption there that I trust the actual number of excess deaths reported. I have to say I don't. I don't trust those. We have a number of data points, particularly out of New York, but there is also cremation and burial data out of the UK, which is not consistent with the total numbers of deaths being reported by authorities in those countries. And I should imagine we would find the similar if we looked into Northern Italy, for example. So that's number one point. But number 2 point, to the extent that there were more people dying than normal, which I'm sure did happen, but probably not to the extent claimed or not within the time series claimed. To that extent, since I had previously said that if we had done nothing and had no testing available, we wouldn't have noticed anything unusual, then that leads on to the it is implicit in that is that I am saying that all the harms caused were caused by the response to the perception of the presence of a novel, dangerous virus.
Well, the reason I asked you that question is what I want to know is in the case of, let's say, New York, if what's going on in the hospitals, if the medical response is, let's say, suboptimal, to put it mildly, what was getting so many people into the hospitals in the first place? Now, we heard over and over the expression, the hospitals are overwhelmed, but in most cases, at least in the U.S., that was never true. And in fact, in April of 2020, there were actually huge layoffs in hospitals. So it's not the story people got. But in New York, there really was a rush on the hospitals.
Well,
so what got them there in the first place?
Though? Was there really?
Oh, I beg your pardon. Maybe I'm wrong.
Jessica Hockett recently published. She has been, obsessively digging into New York. I don't use that pejoratively. I mean, she's diligently digging into New York, and there are so many data anomalies in relation to the story that's coming out of New York. It is difficult to know exactly what happened there. There seems to be so much propaganda that's come out of there. To take for example the refrigerator trucks, there's no real evidence that they were used to proper capacity. There were only 2 out of all of the ones that be reported. I think it's 2 actually were ever had to be sanitized, showing that they were never used. And we see this time and time again with the hospitals being built, the temporary hospitals being built, never being used. And actually, if you look at all the data that she has gathered, the story New York does not resemble the official story. And in fact, she did publish only about a week ago, she published a complete compendium of all the anomalies in the New York data in the story that she has found. And it's what I would recommend everybody to read that, because that's should make people think about the whole story of New York. You've got to remember that it is claimed in New York that this virus, which apparently, and it seems to be accepted even by people in the signatories to the Great Barrington Declaration, that the infection fatality rate of this virus is akin to seasonal flu or lower than seasonal flu, but not no different to seasonal flu, really. I mean, in practical terms. And yet, the number of, I haven't got the figures to hand in New York, but to give you an example, something like, I think it's 25 or 26% of all the people between 20 and 40 who were said to have died from COVID died in New York. So 26% of all the Americans between 20 and 40 or 20 and 50, I can't remember the details, who were said to be COVID deaths died in New York City. That's an extraordinary number. I mean, the number who are said to have died in total in New York is obviously 27,000 over a period of 7 or 8 weeks. That is a huge number. If you think about how many people died in 9/11, this is like a 9/11 incident every single week. And yet there doesn't seem to be any particular interest in investigating whether or not the data is real. And if it's real, why did it happen? What happened to the bodies? Where have they gone? And so on. I mean, it is a very, very interesting situation that there is an event here that if it's true, it needs to be investigated. And if it's false, it needs to be investigated as to why this story has been put forward in the way it has. So New York, I would question the story over New York. That's not to say that I don't believe that nobody got ill, but people get ill all the time. People get ill from respiratory infections all the time, and always have done and always will do. And of course, what we did with since 2020 is we totally changed the way in which we treat ordinary run-of-the-mill respiratory illnesses. Do you want me to go into that in a little bit more detail?
Well, yes, and then I definitely have some follow-ups.
Yeah. So prior to 2020, it seemed to be largely sort of, I don't like the phrase settled science because it has certain connotations, but it was ordinary, standard of care that particularly elderly people, if they got a chest infection, that they would get antibiotics. And the reason for receiving antibiotics was that it is thought not to be viruses per se, influenza viruses or RSV or coronaviruses. They are not thought to directly cause serious illness. It is bacterial secondary infection that causes pneumonia, which is what kills people from when they have these respiratory illnesses. And in fact, of course, Fauci himself had written in, I think it's 2007, written a paper which was setting all this out in relation to influenza pandemics. And he was basically saying that we need to stockpile antibiotics is the most important thing we need to do to prepare for future influenza pandemics. And yet there was not, during the COVID event, if anybody had a positive test, and we all, I think people are working out that the tests were oversensitive and under-specific. But if anybody had a positive test, then they were basically denied antibiotic treatment. And that may well have been harmful in a small number of instances. Now, I don't think for one moment that can explain some of the very, very sharp rises in excess deaths reported in some places, because the timescale is just too short. But this failure to give normal treatment to people with respiratory infectious illnesses, that went on for years, basically, after 2020. So this positive test, which, by the way, we were taught in medical school that all these tests are an adjunct to clinical assessment of the patient. And yet these tests were suddenly used to define a treatment pathway for a patient, which is completely wrong. So I am aware of cases of people who went to hospital with pneumonia, with what would be clinically diagnosed as pneumonia with sepsis, and would have been amenable to treatment with antibiotics. But because the person had a positive test, they were not given that treatment and they died. I'm aware of cases of that in the UK. So if I'm aware of those cases, there must be others as well that happened. So there's definitely been harm caused by changed treatment. The other thing that people seem to not think very deeply about is the role of the pulse oximeter. So if you remember, we had this hysterical obsession with measuring your pulse, your SATs, using pulse oximetry. You know, the little devices that you buy on Amazon or wherever, and you put over your finger and it tells you your oxygen saturation. And I think that the role of these in causing people to go into cycles of fear has been underestimated. Never before during waves of sort of normal winter illnesses have people obsessively measured these numbers. So we don't know how low these numbers go in people when they have run-of-the-mill illnesses. As for elderly people, there are studies that show that people run these numbers in the low 90s quite frequently and quite healthily for long periods of time anyway. And yet, the part of the treatment protocols included the requirement for people to go to hospital if they had sat below 94%. And yet, we know several things. One is that these devices themselves are extremely variable. I don't know whether you've ever fiddled with these devices yourself.
No, I haven't.
Do you know what I'm talking about?
I don't.
Oh, really? So I'm quite surprised. So I haven't got one here other than I'd show you, but a lot of people, there were millions and millions of these little devices sold. They're small devices that go over your finger, and it displays a number that is supposed to be...
I beg your pardon. I do know those. Yeah, I've used one myself.
Yeah, okay, so maybe you call it something different.
I just called it the thing on my finger. I didn't even know what the name was.
So maybe I was too technical. It's called a pulse oximeter.
Okay.
And what was it? Measures your oxygen level every time your blood pulses through your fingertip, and it reports on the screen the number. So that's what I've been talking about for the last few minutes. So the use of these devices, which were bought in their millions, and it was so you had these people obsessively monitoring their number, and of course. These actually, I've been experimenting with them. I'm putting several different brands on different fingers, and it's wild. The excursions are wild. I mean, most of the time it's 98, 99, and then one finger will drop down to 90. Well, if you are told that you need to go to hospital and possibly be ventilated because you are seriously ill if you have a positive test for COVID, and your number on the machine is goes below 94. Can you imagine what it would do to you if you know you've got a positive test and you put the device on your finger and it comes out at 90? So, that would cause in anybody, particularly somebody who's subject to months or years of government propaganda, that would cause somebody to be afraid, to suffer a fear response. And I don't think it's arguable that fear is harmful to health and actually can cause symptoms such as breathlessness, etc. It was no surprise that in the first wave, the CDC analysis sort of, showed that people who were seriously ill arriving in hospital, of the bad outcomes, the second most common factor was that they had high levels of anxiety.
But let me ask you, of course, these devices sold over the counter may be unreliable from like even one brand to another or over time, but surely when I'm in the hospital and the super expensive version is also telling me I'm below 90, does that not mean anything?
Well, as I said before, first of all, we don't really know what during respiratory illnesses, what those used to run at in people with run-of-the-mill respiratory infections before. Secondly, these below the protocol was that people below 94 would be in the early phase of this event were to be ventilated, and there were, but I don't believe that there were sufficient numbers of ventilations to account for the excess waves reported. But also, the machines, by their nature, actually, the machines on your fingertip, even the ones in hospitals, they do show quite a lot of variation. It's really the gold standard for measuring your oxygenation is arterial blood gases, which is quite a painful procedure, but should be done. I don't know to what extent arterial blood gases were measured in hospital before decisions made to ventilate were taken. But the other point I'd make is that you're talking about when people arrive in hospital. What I'm saying is that it is possible that the whole process, the damage was already done by that point anyway, because if you've got individuals who are quite anxiety prone, they put these devices on, and they come out low, and they've got to, let's say they've been taking these tests every day, because some people took these tests every day, as you're probably aware, because they were sort of obsessive about it, because the government made them obsessive about it. You can imagine a situation where the low reading results in anxiety and fear, which actually reduces oxygenation further. And so they are actually, this process at home is making them breathless and making them anxious and reducing their oxygen saturation, so that when they get to hospital, they're already in that state. So they are genuinely have relatively low oxygen levels. Not something that should be treated like they are infected with a deadly bioweapon, but enough to, cause them to, within the hospital protocol, to have some rather dystopian treatments applied to them.
Folks, it's an election year, and that means we are hearing a lot about what's wrong with the United States. But certainly in the top 10 of things that are broken would have to be American health care and American health insurance. It's frustrating. Everybody hates it. It's way too expensive, even though, they did pass legislation called the Affordable Care Act. And yet I have a funny feeling that for you, because I can certainly say for me, it hasn't actually made your care more affordable. Well, that's why we have Crowd Health. It's not health insurance. It's a better way to pay for health care through crowdfunding, because your insurance policy is full of unpleasant surprises. Your premiums keep going up. Crowd Health is doing things differently. For $175 for an individual or $575 for a family of 4 or more, you'll get access to a community of people who are willing to help out in the event of an emergency. You get access to telemedicine visits, discounted prescriptions, and so much more, and you don't have to worry about doctors' networks at all. Let Crowd Health help with your healthcare needs. Get started today for just $99 per month for your first 3 months. Go to joincrowdhealth.com/woods. Crowd Health is not insurance. Learn more at joincrowdhealth.com/woods. That's joincrowdhealth.com/woods. Okay, another reason I think people might be hesitant to accept a thesis that is as radical as what you're proposing is that probably there must have been somewhere in the neighborhood of thousands of journal articles written about COVID, about different protocols that might be used, different factors seeming to affect whether somebody gets it or not. So we would have to believe that, and I'm willing to believe a lot, but we would have to believe that everybody involved in all that research was just chasing after a phantom?
Yeah, well, I mean, I'll make several points in response to that. One is that there has been, over the period since spring 2020, there's been huge publication bias in that only articles which effectively are consistent with this pandemic narrative have been allowed to be published, which is why, our writers on platforms like Substack have, it's taken off and become the alternative. Even the preprint servers such as Medar, RBX and other ResearchGate, they have rejected articles written by colleagues of mine. So, for example, articles written by Norman Fenton and Martin Neal, they've been rejected by the preprint servers, which are, not peer reviewed. And yet, because they were counter narrative, their publications have been rejected. So I don't take the fact that the milieu of publications says one thing as being particularly demonstrative of truth in that sense. Sorry, I could go back to the question again because I've lost my train of thought now.
Well, it's just that so much research has been done. Am I to believe that all these researchers are...
Yeah. So, well, I think people should ask themselves this question. So the pandemic was tracked apparently by, PCR tests and seropositivity, so antibody levels to the novel virus. And yet, there are many places in the world now where if you look at stored samples, and you look at the levels of positive tests when they start testing, before there was any actual reported pandemic, there are several places in the world where it is quite clear that as measured by the same things they used to track the pandemic later, whatever it was, it had been spreading for months before the pandemic started, or was reported to have started. And yet, as it was spreading across these places, and New York is a good example, actually, as it was spreading across these places, it was effectively unnoticed. So there was no excess death, and there was no reported clusters of unusual illness. So all the things that were said to be so unusual about this illness, how come it spread across many places in the world without causing any of these clusters of unusual illness and without causing any excess deaths? And to my mind, the sort of the default explanation for that is that it wasn't the thing itself that was causing these unusual illnesses or the excess deaths. It was actually the response to the perception that there was a pandemic. And it might be worthwhile people reading. So in one of my articles, I talk about the false positive pseudo epidemic that was in Dartmouth Hitchcock Hospital, the whooping cough pseudo epidemic, which I think was 2007, if my memory serves me correctly. So in 2007, there's actually a very good New York Times article on this. In 2007, there was the reports of there was a whooping cough epidemic in a hospital. Whereas Dartmouth Hitchcock is that New Jersey? Would it be, or North Carolina? I'm not sure. Anyway,
Dartmouth is in New Hampshire. I think.
New Hampshire. I think that's right. Well, wherever it is, it's not relevant. But so in this particular hospital, there was an outbreak of whooping cough, and they were basically giving PCR tests to people, and these were all coming back positive. And people were complaining of coughs, and people were saying, "Oh yeah, I've got that cough. I've had that terrible racking cough for weeks." Then going to have a test and getting a positive test, and there was quite a lot of destruction caused by this. And several months later, they actually tried to culture pertussis, which, the bacteria that is associated with whooping cough. They tried to culture that, and they found in several hundred samples completely negative. There was no whooping cough around, and they declared that this was a PCR-driven pseudo-epidemic caused by effectively faulty testing. And yet, interestingly, the people at the time volunteered and said, "Well, I think I've got it. I've got a terrible cough. I've got much worse cough than I normally have." And yet this was a pseudo-epidemic. Now, if you think that happened with no propaganda around, no priming, no fear messaging from the government, and yet this happened within medical staff in a hospital, you can see how those factors would, when given the billions of pounds worth of support by governments, the propaganda, etc., the consistent messaging, the suppression of any alternate voices, you can see how much more likely that would be to happen. The other point worth making is that actually it's quite surprising that bacterial testing theoretically should be a lot easier than viral testing anyway, because it's much easier to test for bacteria. So that's just one example of a previous kind of pseudo epidemic, and that really takes me on to I just said there that people amongst these medical staff, people thought they had whooping cough, complaining of serious cough. That really takes me on to what is called nocebo effect, which I think is another understudied aspect of what has gone on. So you've probably heard of placebo effect,
of course,
which is people get better because they expect to get better by something that's done to them. It's whereas actually they're typically given saline or a sugar pill instead of the active pill, the placebo, and they get better because they're expecting to get better. Well, there is a reverse to placebo effect called the nocebo effect, which is that people become ill because they expect to become ill. And it's a very much understudied phenomenon. But it is basically, if you persuade people strongly enough that they've got symptoms or they've been exposed to something and they should become ill, they will become. There is a high probability that they will actually become ill, and these are very real symptoms to these people, but they're not caused by a pathogenic effect, or they're not true biological. They're triggered psychologically. And I'll give you. I've written out again in my Substack. You'll find some articles if you search for nocebo. Two great examples of this are that in the first one is in the studies where they tried to transmit the common cold to people. And these are going back decades. They've been run studies where they tried to transmit cold and flu from people who are ill to healthy people, trying to make them ill. And they've all largely failed, which is an interesting side discussion, actually, which I don't think we've got time to get into. But I would recommend the book. There's Daniel Roytas, his book, How to Catch a Cold, which goes through the history of trying to transmit these respiratory illnesses between sick and healthy people, and they are virtually all unsuccessful, which is surprising considering what we were told about lockdowns and social distancing, etc. But the point being is that one of these historical experiments contains a fascinating example of somebody who, they go to these units where they're isolated and then they're exposed to secretions that are taken from sick people. And basically this person was one of the supervisors accidentally let slip the fact that this person had been exposed to the live secretions that should have made them, which would make them get a cold. And so this person then got the symptoms of a cold because he'd been told that he'd been exposed to live secretions. But actually, the supervisor who had let slip that accidentally had made an error, and this person had received the inactive secretions. And when this person was told the next day, having developed this cold overnight, oh, by the way, if you heard that you had the live secretions, it was actually a mistake. You didn't. You had the inactive ones. Instantaneously, the symptoms of the cold went away. I find that really quite fascinating because it shows you that these real symptoms can be induced simply by effectively the power of suggestion. And the second great example of nocebo effect, which again, which is well known and well described, was a man who was in a clinical trial, took all his medication, all his clinical trial medication in one go, his blood pressure dropped to very, very low levels. They couldn't get it up in hospital. They couldn't get his blood pressure to rise in hospital. They didn't know what he'd taken. They were quite concerned about him, and they were giving him fluids to try to get his blood pressure to come up. Then they were contacted. The hospital was finally contacted by somebody who was involved in running the clinical trial and said, he's had the placebo. They told the individual that he'd had the placebo, and his blood pressure went within 20 minutes to normal, and he was discharged from hospital. So that, again, is another fascinating example of this much understudied phenomenon, in my view, which is that negative propaganda can basically induce people to become ill. But that was the point of those two stories I told you.
Now, I know that there's a lot more to be said for your position, but I'm going to put some links up at, let's see, what was it again? TomWoods.com/2551 for people to do some further reading. And of course, I'll link to your Substack, which is, what was the?
Sanity Unleashed.
SanityUnleashed.substack.com. But before we wrap up, there's the big question that hangs over this, and you don't have to take a lot of time on it, but the big question that hangs over this is that if what you're saying is true, what does that say about the world we live in, the medical system we live in, the political system we live in? What was something just done to us?
But yeah, it's a big question, and I haven't got, my thoughts on that are not particularly well developed.
And by the way, having clear thoughts on that does not follow from having clear thoughts on the rest of it.
Yeah, absolutely. Yeah. I mean, I think that there are so many factors that could and did contribute to what happened. I mean, one is obviously the power of the industry, the power of the biopharma industrial complex, if you like, which is, in my view, a real thing, and probably is now more powerful and more important in our daily lives than the military industrial complex, for example, or as important anyway. But I think it also says something about our reliance on healthcare and our lack of interest in looking after our own health and seeing externalities always as the solution to our problems. So there's a phrase in that we use here: a pill for every ill. Has come. So you've got depression, take SSRIs. There's high cholesterol, regardless of how harmful it might be. Take statins. There's all these. Overweight, can't lose weight. Take Ozempic or whatever. I mean, it is actually, in my view, it is insane the amount of medication that people are on. So there's a priming there for the acceptance of the vaccinations, for example, in the pandemic narrative. That's a priming for it. What else does it say about I think it says something about, I think there's a lot to be said about social media as well. I don't think without social media and the internet, this global event could have happened, because that's effectively how it happened, was that the fear narrative spread through the internet. Over social media. And I think that's the difference between now and 20, 30 years ago, before the internet was it developed. Something could have happened in one region, but it wouldn't have happened in the other region, and then there would have been an analysis after the event that could have said, well, it didn't happen in that region. Why didn't it happen in that region? They didn't really, and there's a counterweight around the world going on there to the story. Whereas when something happens simultaneously, because social media is dominated by global companies, there's no such correction mechanism in place. So that's one of the points. And there's a general point about centralization as well. In that we're seeing a lot of this was allowed to happen because of centralized global organizations, which implemented the same policies around the world at the same time. So I think, like Nick Hudson, I'm a big fan of smaller decentralization, and these are protections because they protect the error correction mechanisms against these kind of things taking off simultaneously around the world and becoming effectively ideological.
Yeah, there's no question about it. I mean, on the one hand, it really is a paradox, because the internet does allow the emergence of unapproved opinion. Yes, there's been some attempt to clamp down on it, but there's way, way more unapproved opinion out there than there used to be, and independent thinkers all over the place. But on the other hand, wow, does it help to engineer groupthink on a scale never before seen. So it's very much a double-edged sword. I wouldn't want to be without it, but you're right. And then it's also on another level. I don't think we would have all worked from home, quote unquote, if it hadn't been technologically feasible for us to work from home. We would have just figured, well, I guess we just have to do what we have to do. But because we all had Zoom, and because we had these things, because it became possible, we did it.
Well, I think actually another thing is the role of technology in this is quite profound as well, I think, in that we are exposed to these possibilities of these kind of cataclysms occurring because of our over-reliance and overconfidence in technology. So, for example, if you look at the number of pandemics or near pandemics that have been reported since the start of this century, it's 5, 6. And I don't think that is coincidental that we didn't really have this. There's occasional, obviously what is called the Spanish flu pandemic, which is another story altogether, Hong Kong flu. But, these things that society just gets through, really. The Spanish flu one is a very interesting story, which is not all it seems. But maybe the Hong Kong flu and the other flus said to have occurred in the 20th century, but they weren't these cataclysmic events, and they didn't happen at such regular frequency. My theory is that it is now, because of the use of sequencing technologies and hunting for viruses, I think we are finding things that have always been there, and that the pandemics of the 21st century, SARS, MERS, etc., SARS-CoV-2, etc., I think these are a consequence of our overconfidence in these technologies. We don't really fully understand what we're finding. We don't really fully understand what viruses are, how they spread, their role in illnesses, why some people get ill, other people don't get ill, how illnesses are spread between people, if at all. We don't understand this, but we think we do. And a lot of this is related to over-reliance and overconfidence in technology.
SanityUnleashed.substack.com. Jonathan Engler, thanks so much for your time today.
Pleasure. Thanks for having me on.
And thank you, ladies and gentlemen.
Make yourself and those you love less vulnerable to the regime, both mentally and physically. Get more forbidden information at tomsfreebooks.com, and be sure to subscribe to the show wherever you listen. See you next time.
Like the sound of The Tom Woods Show? My audio production is provided by Podsworth Media. Check them out at podsworth.com.